Speaker. I'm pleased to be able to make a contribution to this debate, especially as I've just come from the launch of the 2015 AMA report card on Indigenous health. And I want to commend the AMA for the excellent work they've done and for the content of this document, which will have implications across portfolios within government, but is one which I think should be widely supported by the whole community. And I'll come to it in a moment, because it has particular relevance for some areas of this particular bill. I just remind us, Mr Deputy Speaker, that this year is the 40th anniversary of the dismissal of a Prime Minister, and whilst the dismissal itself is something which has received a lot of media since that day on the 11th of the 11th, what we are seeing, though, is a lack of appreciation, I think, of the important changes that were made to our social policy, health policy landscape as a result of the Whitlam government. And among them is our system of universal health care, which is clearly now under attack by the first, initially prior to this, the Abbott government, now the Turnbull government, with cuts in hospital funding, cuts to Medicare benefit schedule items, cuts to preventative health and public dental programs. And there seems to be, sadly, a continuing but obvious plan under the current Prime Minister, following on from Prime Minister Abbott, to kill Medicare by 1,000 cuts. The latest element of the anti-Medicare plan, the private health survey, a so-called survey but a very poorly concealed push poll, is to undermine the community rating system of private health insurance, which prevents premium cost discrimination on the basis of age, gender or health status. This push poll's timing is interesting, as it coincides with the attempt to push through these changes today to the Medicare safety net contained in this bill. Labor opposes this further attack on our system of universal health care. Broadly, the bill restricts the out-of-pocket costs that count to reaching the safety net. It then further caps on what will be covered towards those costs. The bill therefore seeks to undermine the existing arrangements in which all out-of-pocket costs for out-of-hospital Medicare services count towards the threshold. And once a patient reaches the extended Medicare safety net, 80% of their out-of-pocket costs are covered for our hospital Medicare services, except if it's in an NBS item to which a cap applies. The principles of Medicare that every Australian should have access to the highest quality of care, regardless of their capacity to pay, would be further diluted by this bill seeking to limit the amount patients receive back to a cap of 150% of the NBS schedule fee, less the standard NBS rebate. This bill would have damaging effects on the provision of care to specific groups of people whose health will be seriously diminished by the proposed changes, including, importantly, giving effect to the 2014-15 budget measures, simplifying Medicare safety net arrangements, and, as was a theme with that budget, as well as this government's general approach to the health portfolio, represents a cut to safety nets of $270 million. So if you have a cut, someone's paying, and we know who will be paying as a result of this exercise. The new so-called simplified safety net involves abolishing the existing original Medicare safety net and the extended Medicare safety net, and those changes mean that many patients will reach the safety net sooner, but only in the context of this $270 million cut. So Labor has really serious concerns about the adverse impacts these changes will have on patients across the country. And although the bill lowers the safety net threshold for all patients, restrictions on the out-of-pocket costs that contribute to patients reaching the safety net are introduced, and the amount patients receive back once they reach the safety net is also reduced. We are concerned about the impact these changes will have on radiation oncology patients, patients needing ongoing access to psychiatrists, and IV patients Specifically, I'm concerned about my own electorate of Lingiari because of the changes and the impact they will have on those low socioeconomically disadvantaged patients and Aboriginal and Torres Strait Islander patients, particularly surrounding oncology and psychiatric services. The latest data from the Australian Institute of Health and Welfare indicates that Australian patients continue to incur high out-of-pocket costs for their health care. In 2014, individuals spent an estimated $27.7 billion, that's $27.7 billion, in out-of-pocket expenses on health goods and services. Out-of-pocket expenditure by individuals has grown at a faster rate than overall government expenditure on health. Over the decade, it grew by an average of 6.2% a year in real terms, compared with 5.3% for all non-government sources. In the 2014 budget, 14-15 budget I should say, the Coalition announced that annual indexation of Medicare fees would be paused for 2 years, which was then extended to 2018. This pause in indexation has an effect on the incomes of medical practitioners who bulk bill, as they accept the Medicare benefit as full payment for their services. If practice costs increase, fewer practitioners will be able to or opt to bulk bill, meaning patients will face higher out-of-pocket expenses. Now that's just logical. And the concern I have in particular is the impact it will have on Aboriginal community-controlled health organisations around this country, because they'll have to absorb these additional costs. Ultimately, these safety net arrangements will be manifested. Ultimately, they will disadvantage the most disadvantaged. Health commentator Jennifer Doggett described the proposed lowering of the safety net thresholds as, quote, woefully inadequate to support the increased number of people who have difficulty meeting their healthcare expenses. Anne-Marie Boxall, writing for The Conversation, noted that while some patients will qualify for safety net after spending less money, quote, they will have to pay more of the high out-of-pocket costs than they do now, end of quote. These cuts will hurt people in my electorate, as they will hurt people across the country. But they'll hurt those most particularly live in regional remote Australia, because these are the sickest of Australians. And I'm surprised that our friends in the National Party have tolerated these changes because of the impact it will have on their communities. On the introduction of the bill, AMA President Brian Owler said that the AMA opposed the changes and that the sickest, and I quote, and that the sickest and most disadvantaged Australians will be hit hardest. The Minister says rubbish. Well, maybe the Minister doesn't understand her own legislation. The Royal Australian College of General Practitioners, President Dr Frank R. Jones, expressed concern, quote, that a 150% cap on safety net benefits, when coupled with the existing freeze on scheduled fees, would increase the cost for vulnerable groups. Now, the Minister will no doubt say that's rubbish as well. But clearly it's not rubbish. And medical practitioners who have an interest in looking after their patients understand it's not rubbish, and understand that the people who will be hit hardest by these proposals will be the most vulnerable in the community. And I'm surprised that the Minister should sit there and say it's rubbish, because it's clearly not. Now, I've indicated the advisor's box there shaking his head. It will fall off if you keep shaking it, my friend. You may not like the criticism, but it is valid. And you need to comprehend that the criticism is valid. You may not like the fact that people don't agree with you, but people don't agree with you. And I certainly don't agree with you. And I'm particularly concerned about the impact on cancer patients and psychiatric services. And I'll just go to the psychiatric services in particular, because they relate very well to this AMA report launched today. Because what this AMA report today is about is us appreciating, the community appreciating, the impact of the need to engage health services for the most vulnerable in our community, in this case Aboriginal and Torres Strait Islander Australians. And this particular document addresses those Aboriginal and Torres Strait Islander Australians who are incarcerated. And what it identifies is the high level of cognitive impairment and other mental health issues that the bulk of Australia's Aboriginal and Torres Strait Islander incarcerated men and women suffer from. Now that raises particular issues around the provision of services, not the least of which are psychiatric services. And the question of access to services is something which I know and I hope the Minister acknowledges. But if we want to get, we've got an enormous problem with the high incarceration rates of Aboriginal and Torres Strait Islander Australians. And we know that Aboriginal and Torres Strait Islander Australians continue to experience life expectancy of around 10 years less than non-Aboriginal and Torres Strait Islander Australians. Now that's a national tragedy, as we know, and I have to say, and I compliment the government, we're all involved in a bipartisan way in trying to close the gap. That's understood. But there are elements of government policy which are counterintuitive, because what they're doing is undermining that objective. And this particular piece of legislation is one of those counterintuitive pieces of legislation which actually is counterproductive in the prospect of closing the gap, and in particular in terms of addressing the health issues of Australia's Aboriginal and Torres Strait Islander people who are in jail. Aboriginal and Torres Strait Islander people, and I'm quoting now from the AMA's press release from today, comprise 27% of all sentenced prisoners and 29% of people awaiting sentencing. They are 13 times more likely to be imprisoned than their non-Aboriginal and Torres Strait Islander peers. The imprisonment of Aboriginal and Torres Strait Islander people is rising, and that really is something which is of grave concern to all of us. And of course, the situation for young Aboriginal and Torres Strait Islander people is even more distressing. In 2012 and 13, Aboriginal and Torres Strait Islander 10 to 17-year-olds were 17 times more likely to have been under youth supervision than their non-Indigenous peers. This is unacceptable, say the AMA, and it is unacceptable, as I'm sure everyone in this chamber would acknowledge. And what this report card does, though, quite significantly, and this is what is important about it from my perspective as someone involved in health, this report card recognises that shorter life expectancy and poorer overall health for Indigenous Australians, and I'm quoting here, is most definitely linked to prison and incarceration. Now, these health issues, they say, must be targeted as part of an integrated effort to reduce Indigenous imprisonment rates. Now, what this means is that we've got to make sure people get access to these services. And if you make it more difficult through imposing additional costs, in this case for access to psychiatry services, then you're impeding the possibility of people with a mental illness getting proper services. Now, the Minister smiles at me saying, well, you don't know what you're talking about, she says. Well, let's be very clear. Let's be very clear. Dr Shirley Prager, the President of the Association of Practicing Psychiatrists, has pointed out, quote, if the new safety net is legislated, a significant group of high-needs patients are poor and unable to work as a consequence of illness, and the intensive psychiatric help they urgently need to rebuild their lives will be lost under the new safety net. Now, is that true or not true? I just asked the Minister to respond. Now, I'm assuming that the Association of Practicing Psychiatrists know what they're talking about. I'm assuming this association has spoken to the Minister, or the Minister's taken the time to try and seek their counsel. The Australian Institute of Health and Welfare report cited the Health and Welfare of Australia's Aboriginal and Torres Strait Islander Peoples 2015 stated, amongst other relevant data, that mental health-related problems accounted for 11% of all problems managed by general practitioners for Aboriginal and Torres Strait Islander patients in 2008 to 2013. We need to understand that we can't be actually working together, as we're trying to do, to affect change in Aboriginal and Torres Strait Islander health outcomes, while at the same time introducing legislation which makes it more difficult. And that's all I'm saying to the government. Just look at it. Don't take my word. Take the word of the AMA, the Psychiatrists Association, the GPs around the country. Don't they know what they're talking about? Well, they might not agree with you, but at least you'd acknowledge their arguments and you could say quite clearly that you're going to address them. Well, frankly, I haven't seen them addressed in any contributions to this debate. I hope in the summing up that the Minister might actually do address them and assuage the concerns of those so many tens of thousands of Australians who will be impacted by this piece of legislation. It's not good enough. It's not good enough. We have a responsibility in this country and in this parliament to make sure we look after all Australians, and that's why we'll be opposing this legislation.
The question now is that the amendments be agreed to. I call the member for Grey.